So the first question is, we discussed in Dr. Marcia's talk already. So which of these will support your decision to start CPAP compared to needing intubation and ventilation? Of course, the decision is not a straightforward one, and it will depend on multiple factors. So this is just to get the concept of what is important. So any of you can unmute yourself and answer.
Adequate respiratory effort with normal tone, sir.
Can you explain it better? Compare, I mean, just go through the other points one by one and why they would need ventilation better.
Sir, CPAP is better for a continuously for a baby who is spontaneously breathing, and for babies who requires FI out of 0.6 to maintain saturation and all. Obviously, we need a machine, sir, a ventilator. And if baby is having recurrent apnea and desaturation, then also it will be very difficult to maintain on CPAP, sir. We have to go for ventilator. And for on a blood gas analysis, if the PCOT is going more than 65, that is more, sir, actually. So in that case also, we need a
Yes.
ventilator only, sir.
So, I mean, we discussed in Dr. Pratim's presentation last week about the threshold and when you would intervene, when you would intubate, and why he started CPAP in the beginning and so on. So, this is a similar situation. Of course, you have clear-cut criteria where you definitely say this baby won't tolerate. And if there is inadequate effort, then it's an absolute failure for CPAP. So, you wouldn't consider CPAP where recurrent apnea and desaturation comes with the poor effort as well. So, you may have to intubate and ventilate such babies. Thank you, Dr. Prithvi, for the answer. So this is a question on whether you would intubate a baby based on PCO2 of 72 on venous gas. I mean, some of us have a practice, if the cannula is inserted and you don't want to prick the baby twice, you may use a venous gas as a trend. So in this question, the CO2 came 72. Would you intubate the baby immediately, or what would you be thinking about?
No, sir. We will see all other parameters also. Clinical history.
Yeah, Dr. Palnivel, do you want to answer?
Sir, I thought we should intubate.
This is a venous gas.
Okay, sir. Oh. Okay.
So what would be your next step of action?
Sir, we
So
can
venous
try
gas-
on CPAP.
Yes, we can start.
No, the first step would be to repeat a reliable gas. So you would do
Repeat.
a.
It
should be repeated with
Arterial
ABG,
sample.
arterial blood gas.
You can
Because
start
PCO2 is
CPAP,
high
but
already in venous gas analysis.
arterial gas is not readily available, and the expertise is more. So you will do a arterialized capillary sample in these cases. So you will warm the heel, and in the meantime, you would give some form of respiratory support. Of course, if the baby has no effort or is collapsing, you would intubate the baby, but that's different. But if the baby is suitable for CPAP, you can consider, and you wouldn't rely just on the venous gas because the CO2 quite unreliable, and depending on the circulation and the hemodynamics on the baby, venous gas can show a very high CO2, which if you do a capillary gas, sometimes it comes in the 50s in this baby. And you can manage, this baby will improve with non-invasive support as well. So the point is that you shouldn't rely on a venous gas to make decisions. You can use it only to make trends if you happen to do it. But if you need intervention, just do the intervention that is clinically indicated and repeat the gas zone. Is that clear? So I don't know how many of you use pre-medication for intubation, but there are some situations where you would consider it. It's not essential in some setups where you're not sure about the backup, but most of us say the humane way to intubate is better, the bigger babies who are fighting especially. So in what settings would you consider pre-medication? So Dr. Momita, do you want to answer this? Anyone else? Dr. Payal?
Elective intubation for
Active
surgery.
intubation for surgery.
Elective intubation for surgery, I guess.
And what about insure? I mean, there is a debate in some circles about whether you need to pre-medicate, but that may affect your ability to extubate immediately. So that would defeat the purpose sometimes. Dr. Akansha, do you use pre-medication in your unit?
No, sir, we use pre-medication in PICU only for large babies. But in neonatal units, we don't use that much.
So the practice is quite variable, and obviously, if you are using pre-medication, we consider fentanyl with dexamethasone in most of the cases, and now other options are also available. Not everyone uses pre-medication because sometimes the baby becomes difficult to bag after fentanyl, and some of you have seen severe reactions like chest wall stiffness. But it does make intubation easier. So if you are someone inexperienced doing the intubation, the risk of trauma is less. It's less stressful for the team. You don't need to pull and cause injury. When people are learning, where you have students, in UK, that's why they stress on this method, but with video laryngoscopy as well, I mean, with people are more in control of the procedure. So if you're able to do it in a elective surgery in the anesthesia table, definitely. Or if you are doing elective intubation in a big baby in the NICU for PPHN or something, you can consider pre-medication. But be sure you have the expertise to manage if the airway is difficult. Dr. Pratin, you wanted to make a point?
Sir, for Ensure, we used to do pre-medication with atropine, phenterlin, and succinylcholine. But in my experience, sir, we usually after Ensure, we immediately put the baby to CPAP, and we didn't find much of difficulties after that. That baby not able to have a good respiration after that. But yeah, we do have to keep on ventilating for a couple of minutes till the baby gets his own good respiratory effort.
Did you face any chest wall rigidity with fentanyl? The key is to give very slowly, over 3 to 5 minutes. If you push it, by mistake, it goes into chest wall spasm. And then you have to give the dexamethasone quickly. And you have to be expert in maintaining the airway open when you bag such babies.
No, sir, we didn't find that much chest rigidity yet. But nowadays, I don't use pre-medication for Ensure.
I mean, as your expertise increases and you're more gentle with the actual process, it may not make a huge difference, but with inexperienced intubators, definitely pre-medication is a consideration. Dr. Karthik, you want to comment?
Thank you, Sridhar. Actually, just a small ethical issue which has been raised in recent circles last 4-5 years. We do a lot of Ensure and Lisa in our unit. So not giving pre-medication is an accepted norm in Lisa because now we don't give any sedation before Lisa. We just quietly do it. A lot of ethical issues have been raised whether child should not be probably experiencing the pain and the stress level when these procedures are done. So when this comment just now was made about not using any pre-medication, I hope you're at least giving some sucrose or some kind of pain or some relief during the procedure. Maybe and usually we would give fentanyl before giving Ensure. But Lisa, we personally we don't do it. So a lot of ethical issues are being raised. So this will anyway address it in our when we talk about Lisa. That's the only comment I had.
Thank you. So I think you might have reviewed in my video about the ventilation perfusion ratio. And here when we say ventilation perfusion ratio increases, obviously the ratio increasing means perfusion is reducing and decreases means the other way around. So in this question, I mean, just address one point at a time. Who wants to take the first point, the PDA with left to right shunt? What happens to the VQ? Dr. Avneet, you want to comment?
Yes, sir. Sir, in case of the large PDA, when there is left to right shunt, the blood flow decreases. So the perfusion will decrease, whereas ventilation is maintained. So VQ ratio will be increased. It will be higher.
So you have left to right shunt, which means there is overflow in the lungs.
Overflow. Yes, sir. There will be overflow. Perfusion will be more.
Yeah, but what happens when the perfusion is more? Sometimes you get pulmonary edema.
Yes, sir. Pulmonary edema will result in decreased ventilation. So VQ ratio will decrease in this case.
So yeah, you understand?
Yes, sir. Yes, sir.
Okay. In PPHN, the other way around. Okay, the PPHN, the physiologic dead space
the flow will decrease.
Shunting will be happening. There will be what we call, I mean, if the blood flow persists and the alveoli is closed, like in meconium aspiration, we will discuss that next. Dr. Saravana Raja, do you want to mention on congenital pneumonia?
In congenital pneumonia, oxygenation will be affected, sir.
Yes, I mean, you're talking of ventilation, no? Right, ventilation. Okay.
Yes,
yeah.
Sir. So the weak ventilation perfusion ratio will decrease.
Correct. So most of the time it's purely, but in severe hypoxia with congenital pneumonia, or if the baby is in shock, you might have a combined picture. So it may,
Picture.
the circulation may drop as well. So remember that primary respiratory pathology can affect the circulation either through vasoconstriction because hypoxia causes PPHN-like setting or due to shock-like situation. You have a very nice indoor garden.
Thank you, sir.
You have a passion for plants. Dr. Gaurav, do you want to answer the third one?
Yes, sir. In meconium aspiration as well, the ventilation will go down and the perfusion will remain normal until the baby is in shock. So the VQ ratio will decrease.
Yes, most of the situations. When meconium aspiration is one of the most challenging cases to ventilate because what we call as non-homogeneous lung disease. So you may have areas of atelectasis where you will have shunting because there is no the physiologic dead space rather, and I mean both will be there. You have areas of collapse, you have areas of overinflation. The over-distended areas may compress on the vasculature. So it's mostly a mixed picture. And what happens to the VQ mismatch depends on which aspect is playing a bigger role. So you have both could be playing a role. And of course, with meconium aspiration, you know, PPHN also is common. So it's a mixed bag. I mean, it depends on the baby and your luck. You end up with MAS with PPHN, good luck to you. Okay, so Dr. Samarth, you want to take the fourth one, bronchiolitis?
Yes, sir. In cases of bronchiolitis, sir, there is increased resistance amongst the lower bronchioles due to edema and mucus plugging and all. That is why the ventilation decreases.
Yes.
As a result, the VQ ratio will decrease, sir.
Dr. Priya, do you want to take the last one?
Sir, in collapse of in atelectasis of lung segment, there will be compromise with ventilation, sir. So ventilation perfusion ratio will decrease.
You have any questions on this concept of ventilation perfusion mismatch? Because that's most of the lung diseases are related to the the alveolar pathology. So ventilation will be affected, but remember that the circulatory changes can happen, and in BPD patients, we have a component of both in many of the situations. So management of BPD patients, it becomes quite tricky often with the intrapulmonary shunting. So these babies go into BPD spells, the vasospasm, very difficult to manage these babies as well. So just to understand the concept, and this is next question. Again, you have to try and fit which one of these will be a type 2 respiratory failure. So Dr. Janika, do you want to try? You can go one by one yourself.
So RDS with PIE, this can be initially the RDS, it may cause type 1 failure.
Yes.
And PIE, it may result in type 2 failure. Sir.
Yes, severe
So
PIE or lobar emphysema and conditions or pneumothorax may affect, become a, I mean, type 2 is not just effort, it's also ineffective gas exchange. So the ventilation is not happening. So it could be initially with the type 1, but it can progress to a type 2 as well. And again, if the RDS is not well managed, the baby may become hypoxic and the respiratory effort may start failing, but that's quite late when we say the baby is tiring out. So then when the baby is tired, it becomes a type 2. Do you want to answer the next one or we'll pass to the next person?
So I can answer the next one also.
Yeah.
In meconium aspiration syndrome with birth asphyxia, here MAS, this basically if it's birth asphyxia and HIE stage 2, it will be a type 2 failure.
Yes.
And MAS may be a type 1 failure, sir.
Yes, so it could be a combination, and what is predominant depends on the severity of the neurological injury and whether you needed any treatment.
Yes, sir.
So who wants to take the next one? Dr. Marcia, do you want to comment?
Okay, yes, a floppy baby neuromuscular will probably have difficulty in initiating breaths. So this one will most likely be a type 2 because they can't clear the carbon dioxide.
Dr. Momita, the next one.
Sir, baby recovering from general anesthesia also have poor respiratory effort. That's why baby may have type 2 respiratory failure.
Yes. So it's clear the concept of type 1 and type 2. Dr. Mala, do you want to mention the last one? Or Dr. Bindu?
Hello, sir. babies having poor effort after sedation for MRI is also a type 2 respiratory failure.
Yes. So type 2, the key thing is mostly the effort is not there. The first question about effort and CPAP. So you wouldn't consider non-invasive ventilation in these babies. If they're having a type 2 respiratory failure, you have to intubate these babies. The other important point about type 2 is that the lung is relatively normal unless you have a coexistent pathology. So most of the time your ventilation requirement will be quite low. So remember these 2 points when it comes, and most of these babies are already having a poor effort, and you don't need to consider sedation or anything for these babies. So they can be intubated directly. Pre-medication again is a question we discussed. So you may consider it if you feel the baby is awake enough to feel the pain. So with this, we will stop the MCQs.